We would discuss diabetes mellitus today. If we have time on our side, we will look at the complications, the metabolic complications of diabetes mellitus as well. If not, we will discuss that during the emergency medicine session that we would have after we are done with internal medicine too. But I'll be glad if we are able to discuss that today, because most of the cases that would end up coming to you at the ER who come as diabetics would be having this metabolic complication. So I think it will be better, as we discuss diabetes mellitus, we would also touch on the metabolic complications and know how they are managed, but it all depends on how time will go. So we'll go through the basics, which I'm sure we all know one or two about, but it's always good to revise. So we'll go through the basics, and then afterwards we would look at the metabolic complications as well. Okay. So I expect that by the end of the lecture, at least you should know what diabetes mellitus is. You should know the types, the risk factors, the pathophysiology, some of the clinical features you expect to see, how you would investigate a patient or make a diagnosis of diabetes mellitus, and how you manage. This lecture actually covers management in the OPD or the outpatient section. Once we touch on the metabolic complications, it would direct us to the inpatient management or the emergency medicine management of the patients who we tend to get on admission, who come with complications or metabolic complications of diabetes. So a brief introduction. We know that diabetes has been there since, and it's rather getting worse, and basically due to our lifestyle. Okay, the lifestyle isn't getting any better. Once we look at risk factors, you'd see that sedentary lifestyle, which would lead to obesity, the diet and everything doesn't really help or do us any good when it comes to preventing diabetes, and it's rather getting worse. And sometimes you can't do anything about it because you go to work, you come back late, you'd have to eat late and all that, and everything gets difficult. You are rushing to work, you're unable to exercise and everything. So it gets so tight, you are stressed. All of these things will lead to the body, one way or the other, being unable to handle sugar, or it will make glycemic control poor. And this would eventually lead to you having or developing diabetes mellitus. So you can see the statistics, and it keeps going up, okay? So basically, once we talk about diabetes mellitus, we want to say that the patient is experiencing what we call chronic hyperglycemia, okay? And this chronic hyperglycemia is due to one, insulin deficiency or resistance, or sometimes even both of these factors that we've talked about. The patient might have both insulin deficiency and insulin resistance. What do we mean by insulin deficiency? Let's go a little bit into our anatomy and our physiology. You remember we said that there's an organ that sits there close to the epigastrium, the abdomen, called the pancreas. And the pancreas has beta cells, okay, of the islets of Langerhans, and these are responsible for making insulin. And there are conditions that would lead to improper functioning of these beta cells. Or sometimes there are autoimmune conditions, or sometimes a patient would develop some form of tumor that would lead to resection of the pancreas. All these things will lead to a defective beta cell function. And once the beta cell function becomes defective, then it's unable to make the insulin. Then clearly you have what we term as insulin deficiency over there, right? Also, you could have a system which is making enough insulin. However, the insulin is supposed to affect certain parts of the body, i.e. the muscles, the fat cells, so that they will be able to take up glucose from the bloodstream and reduce the glycemic level. But sometimes the body, faces some sort of resistance, and this sugar level in the blood, there's a problem where the fat cells and then the muscles are unable to take up the sugar in the blood. And once this happens, we say that there's some sort of resistance, to the insulin. And it's not because the patient doesn't have insulin. The patient has enough insulin in the blood, but the insulin is unable to bind to the cells of the fat cells or the muscular cells to cause that cascade where you need to uptake the sugars in the blood. So once this happens, we say the patient has what we call insulin resistance. So there's insulin, however, the insulin is unable to effect receptor cells on the fats and then the muscular tissues. We say diabetes mellitus is irreversible. So once you develop it, it would usually get worse if you don't manage. And once you develop it, when you manage, it's not going to reverse it. Once we say that you have diabetes or full-blown diabetes, your management won't reverse it, but your management will rather keep your glycemic level under control. And whenever you dip or you fall in terms of management, the sugars will go up again and you start having effects. So usually people who have DM are able to live a normal lifestyle. Once you manage it well, you should be fine. But then sometimes the later complications that arise with this is what tends to lead to a reduced life expectancy and sometimes tend to lead to morbidities. And we'll be looking at that when we get to the complications. So in terms of classification, we have type 1 and type 2 diabetes, which we are all aware of. And this type 1 and type 2 will fall under primary diabetes. Primary diabetes here means that the reason or the main reason why the patient is diabetic is directly linked to insulin production, right? So in type 1 diabetes, there's diminished insulin production because of most of the time an autoimmune condition, which has basically affected the pancreas. And in type 2 diabetes, there's some sort of insulin production, but then the function of the insulin is not really seen because there is a resistance to the insulin that is being produced by the by the pancreas. So clearly you can see that both type 1 and type 2 have something to do with insulin. Either insulin is not being produced or insulin is produced, but then its function is impaired due to resistance. Secondary diabetes will look at other things not directly related to insulin. So this secondary diabetes or secondary diabetes mellitus here would also look at a chronic hyperglycemia, but this wouldn't be directly due to insulin one way or the other, or it could be coming from a condition that is affecting the pancreas. So for instance, you can have pancreatic disease. So you can say that this patient has diabetes mellitus secondary to maybe chronic pancreatitis, or patient has a diabetes mellitus secondary to CA of the pancreas or carcinoma of the pancreas. Or sometimes you can have surgery that they will end up having to remove your pancreas, so we call pancreatectomy. So then you develop diabetes, and this your diabetes will be secondary to the surgery that you've had. So there are other conditions like we know that insulin as a hormone can be affected by other hormones, okay? Usually when you look at how the system works, insulin, if you need something to come in to control the level of the sugar in terms of trying to push sugar into the cells to reduce the sugar in the bloodstream, then you call on insulin. But then if you need excess sugar in the bloodstream, then you call on the opposing hormones to insulin, okay? And what are these hormones? We have growth hormone. Usually, these hormones, once they come in, will tend to act opposite to what you expect that insulin will do, okay? So, for instance, if you have a patient who has what we call Cushing syndrome, where the cortisol level goes up, we are saying cortisol would act in the opposite direction of insulin. So, whereas you expect insulin to come in and regulate blood sugars and keep blood sugars down to the normal level, once you have excess cortisol level, what happens is that your blood sugars will go up. The same goes for acromegaly, which is also due to excess of growth hormones. As you know, once growth hormone level goes up, then it means sugars will go up and you tend to have chronic hyperglycemia. Once you have excess thyroid hormones, which also has sort of an opposing effect as what insulin has, that will also cause your sugars to go up. If you have excess adrenaline production, which also the same thing has an opposing effect as what insulin has. So you tend to see excess adrenaline production in a condition called pheochromocytoma, which is a tumor that sits in the adrenal medulla and then keeps producing excess adrenaline, non-adrenaline. Then if you have a glucagonal mass, you can see it means that there's a tumor which is making excess glucagon. And we know that glucagon will have an opposing effect as insulin. So this will cause the blood sugars to go up, okay? So in this case, you have diabetes mellitus, which is secondary to another condition, okay? Then also you can have diabetes mellitus or chronic hyperglycemia, which is secondary to certain use of drugs. So diuretics, for instance, we know that affects the sugar control and metabolism. And usually we don't like to give it to our diabetics because it tends to make the diabetes worse. Steroids, as I always mention, also would have a negative effect on sugar control and cause hyperglycemia. Beta blockers also tend to have a similar effect. Certain genetic conditions like Friedreich's ataxia and dystrophia myotonica, all of this tend to have negative effects on sugar control and would lead to a chronic hyperglycemia. In this case, we say chronic hyperglycemia secondary to these various diseases that we've listed there. It tells us that in the absence of these diseases, ideally, sugar control would be perfect, but because of the presence of these diseases, we would develop a chronic hyperglycemia. So as you can see, type 1 diabetes, our focus is actually going to be on primary diabetes, okay? But I chipped in the secondary diabetes so that you know that sometimes you can be managing your patients with COVID who is not diabetic, but then all of a sudden the sugar starts going up. And that tells you that, okay, let me go and take a look at my management. I'm giving the patient steroids. Oh, so this hyperglycemia is secondary to the methylprednisolone or maybe the hydrocortisone I'm giving my patient. You understand? So the secondary causes is very key. Pancreatic carcinoma, who is going to have a pancreatectomy done, then you know that after the pancreatectomy, your patient should go on some insulin because basically you are taking the pancreas out. The patient is going to develop poor control of sugar and the patient can become diabetic. So it's there to remind you that apart from the usual type 1 and type 2 that we are aware of, other things can also lead to chronic hyperglycemia. So usually in type 1 diabetes, we say that there's total deficiency of insulin. So most of the time is due to an autoimmune disease, which destroys the pancreas from childhood. So this patient would usually be less than 30 years. And then most of the time, they tend to be lean. Okay. It's like they eat a lot, but then once they eat, the sugars and all that don't go into the body tissues. They don't gain weight. They keep peeing and peeing and peeing. They keep eating, but then there's weight loss. Okay. And then there's type 2, which in this case, there's sometimes the insulin is even there, but then, as I said, there's a resistance because the receptors where this insulin is supposed to be binding to have been covered by something else, if you can look at it that way. So if you have excess fat prevents the insulin from, binding adequately to the receptors to cause a cascade whereby the sugar is properly regulated. And once you have this happening, you are going to develop hyperglycemia, even if you have insulin. So you have the insulin there, all right, but then because of the resistance the insulin is facing, the insulin is unable to work. And this is the type of diabetes that we tend to see. We tend to see this more common than the type 1. So most of the people who come to us at the OPD are type 2 diabetics. It usually occurs after 30 years. The patients are usually overweight. Okay. And then they come to you. So that's one of the ways you can distinguish the type 1 from type 2. We've been talking about insulin. So insulin is a hormone and insulin is responsible for blood glucose regulation. To understand diabetes, you need to know the role insulin plays. So what insulin does is that, yes, hi.
So please with the type 2, like if there is a partial resistance, then why then would they become overweight? What causes the overweight?
So the overweight is not because of it's not due to the partial resistance. The partial resistance is rather due to the overweight. So the overweight there is a risk factor for you developing the diabetes. It's not the other way around. It's rather the risk factor for becoming overweight. But rather when you become overweight, then there's a resistance. So it's the other way around.
Okay.
Sir, please, I have a question about the same resistance.
Yes.
Now, sir, please, I want to know. So over the years, is it that the ligand, as in the glucose, that has changed shape for the receptor, or the receptor is not able to recognize the same ligand it used to? Because if you about the cell signaling, I want to know if there is a problem with the cell signaling, or it is just the case that as you grow at a point due to familial tendency or whatever, the shape of the glucose you try to produce will become different, or the receptor itself will become different. So I just want to know.
All right. So with this, then it means you have to go more into what we call signal transduction, and that's like something deeper. Okay. But what is happening is that it is not just a straightforward thing that once you become obese, you are going to develop some resistance because the fat cells over there would basically prevent the sugars or the glucose and the insulin from being able to bind to the receptors on this fat cell, on the muscular cell. Ideally what's supposed to happen is you have receptors on these tissues, the fat tissues, the muscle tissues, and the insulin that your body makes should be able to receptors on the fat and muscle tissues when you eat or in the midst of glucose. You get it? So once it goes to bind to these receptors, then you have a cascade. You have your signal transduction where after the insulin binds to, it's not the glucose going to bind. after the insulin binding to the receptor on the fat or muscle cell, then it induces a whole cascade where afterwards glucose in the blood is now pushed into fat cells and muscle cells. Do you get it? Do you get the pathophysiology there?
Yes.
Great. So it's not about the glucose just going to bind and you're thinking, okay, would there be conformational change of the receptor or the glucose? No. The glucose is there in the blood. It's the insulin that has to bind to the receptor. And once the insulin binds to the receptor, that is going to induce a cascade, which would eventually lead to pushing of the glucose from the bloodstream into the fat and muscle tissue. So once you have some sort of resistance, which we are saying that one, there are a host of risk factors, and it's not just about being obese. Otherwise, all obese people will have diabetes, but also being obese and having something like a family history and all that, it comes together. You get it. So it's not just a straightforward thing that you are obese. So great. So all of this will come together, and then it makes the receptor resistant to the insulin. So the insulin is unable to bind to the receptor to cause the conformational change. It's like the insulin is getting close to the receptor, but there's no attraction. There's rather a repulsion. And once the insulin doesn't bind to the receptor, then you are going to have excess sugars in the blood. You get it?
Yes.
Great.
I get.
Great.
Thank you very much.
That's an interesting question.
Yes, it's a very deep question. All right. Okay, so let's look at the pathogenesis. I mean, we've already talked about this, and we also looked at it in the question. The type 1, we're saying autoimmune disease. So usually, that's why it's common in childhood, because most of these autoimmune diseases will start in early childhood. So you realize that you have a child who is not gaining weight and is consistently becoming lean, showing all the symptoms of diabetes in terms of polyphagia, that's eating a lot. At the same time, there's polyuria. The child is predisposed to lots of infections. And this is because the autoimmune disease of the pancreas leads to destruction of, as you can see, the islet cells. And this islet of Langerhans is what has the beta cells and is supposed to make your insulin for you. So once it's getting destroyed, then you have a deficiency of insulin production. That's type 1. And we're saying type 2 is actually due to peripheral insulin resistance and sometimes inadequate insulin secretion by the pancreatic beta cells. Why are we saying that inadequate insulin secretion? Why are we saying type 1 is due to inadequate and then type 2 is also sometimes due to inadequate? What happens is, even in the management of your diabetes, once you make a diagnosis of type 2 diabetes, some of the medications that you give would eventually lead to destruction of the beta cells of the pancreas. And eventually, you are not going to be struggling with only insulin resistance, but you're also going to be struggling with decreased production of insulin. At the same time, the diabetes itself, if you decide not to manage it, with time, apart from the fact that you have insulin resistance, it gets to a point where the beta cell actually fails and it wouldn't make any insulin at all. And that is why when we are counseling most patients with diabetes, we don't tell them that, oh, if you don't take your medication, I'll give you insulin, so that we make it look like insulin is a punishment. No, because most of the time, most diabetics would eventually end up going on insulin. Because if we are just talking about only insulin resistance, then it means we wouldn't worry about giving the patient insulin. But there are type 2 diabetics who are not taking pills, but are taking insulin shots, because the pills won't work for them. Because in such patients, they've gone beyond insulin resistance, and now they've gotten to a stage where the pancreas is not making insulin at all. So they have to resort to only insulin shots. Okay. Do you get the analogy or what I'm trying to say here? If you don't get it, I'll go over, because this is
please
very
come
key.
again, sir.
Okay, so we're saying there's type 1 and type 2 diabetes. And if we say someone has type 1 diabetes, clearly it means the pancreas is not making insulin at all. And you don't waste your time giving the patient oral glycemics, okay, or oral hypoglycemic agents. No, you don't waste your time giving your patients such medication, because those medications, once you take, sometimes go and then it goes to help with insulin resistance and whatnot. For instance, if you give metformin, it goes to help with insulin resistance and prevent insulin resistance. We'll get there. But this patient is not even making insulin in the first place. So even if you give a medication to go and help with insulin resistance, it won't work, because the patient doesn't even have the insulin in the first place for you to be worrying about insulin resistance. You get that point?
Okay.
So for such cases, you give them insulin. But for type 2, you are saying that they can either be due to insulin resistance. In fact, most of the time is due to insulin resistance. So in this case, you can sometimes manage with your oral hypoglycemics, but eventually they would end up developing a beta cell failure, or the pancreas cells that are supposed to be making the insulin will eventually fail in most type 2 patients. So it gets to a point where the oral pills you are giving won't even work. So you will have to give this patient insulin, because eventually the beta cells will stop making insulin. You understand?
Oh, okay, sir.
So I was giving an example. I'm coming just in a bit. I was giving an example that most of the time when we have our diabetics and we want them to take medication, we tend to scare them and say, if you don't take your medication, we'll give you insulin. If you scare them, they will feel insulin is a bad thing. But you just have to let them understand at the onset of the disease that this condition might eventually end up in a beta cell failure. And when it gets to that point, we'll have to stop giving you the pills and you'll be on insulin shots. You understand?
Okay, sir.
Great. Let me take the question. I think there was a question coming.
I was asking if question one, is insulin resistant diabetes or it is pre-diabetes? 2, when it's insulin resistant, right?
Okay.
Is insulin resistant a pre-diabetic stage, or it's diabetes itself?
Okay.
And then the second question is, when you are managing like a diabetic patient and you are giving him metformin, you just said that it ends up destroying the beta cell, meaning
not metformin per se, but the other ones that we'll be talking about, your sulfonylureas, would end up having an effect on the beta cells.
Very good. So when it have effect on the beta cell, and you give insulin shot, it means that you are giving insulin shot, and you are also would you also be managing with the same metformin again, or that one you take it off whilst you are giving insulin shot?
All right. Okay. So we'll get there. So that's more of management. So we'll take that question when we get to management. There's a role of just doing insulin, and there's a role of doing a combination of your insulin and oral hypoglycemics like metformin, especially if you are being faced with insulin resistance. We'll get there. So remind me that we'll take that question. But your first question, insulin resistance, for you to make a classification or for you to categorize a patient as pre-diabetic, it's not dependent on insulin resistance. We look at the values that the patient has. Okay. So when we get to diagnosis of diabetes, you realize that they've set, targets that if your fasting blood sugar is above 7.1, right, we say you are diabetic. If your random blood sugar is above 11.1, we say you are diabetic. If you are doing values of about 6.1 to maybe 7.1, then of fasting blood sugar, then we need to counsel you, because then you are in the category of impaired glucose tolerance, or what we call a pre-diabetic stage. You get it? So in that scenario, we use those values or those parameters, because you can have a patient who is obese, has a family history, and whose pancreas is functioning well and making insulin. But because of the obesity, there's some form of insulin resistance. So this patient's fasting blood sugar is persistently above 7.1 and random blood sugar is persistently above 11.1. You don't say this patient is a pre-diabetic. You understand? This patient is clearly a diabetic, and this patient would have to go on medication. Are you okay with that? Are you okay? Hello?
So I'm okay with it. I'm okay with it.
All right, okay. So you look at the parameters, okay? You don't wait for inadequate insulin production before you pronounce the patient as diabetic. And as I said, for even type 2, most of them in the initial phase would be producing insulin adequately, but the issue would be the peripheral insulin resistance. If you just want to say, oh, maybe you are making insulin, but because it's just peripheral insulin resistance, so let's say you are pre-diabetic, no. We don't base our diagnosis on pre-diabetes on peripheral insulin resistance. If you have peripheral insulin resistance and this peripheral insulin resistance is affecting your glycemic level and you are having values higher than what we expect in diabetes, you are a diabetic. We will only say you are pre-diabetic if you are having values in the pre-diabetic range, okay? So risk factors, we said type 1, there's genetic susceptibility, autoimmunity, and sometimes when you're exposed to certain viruses, like the enteroviruses, you can develop type 1. These enteroviruses are usually common in childhood. And then type 2, increasing age, obesity, family history, if you are Black, if you were born with low birth weight. Research has shown that when you grow, there's a risk of you developing diabetes for one reason or the other, which they are still doing studies on. People who are hypertensive and also have high cholesterol or lipid levels, as in hyperlipidemia, tend to be at risk. History of gestational diabetes. So if you have a pregnant woman who you make a diagnosis of DM during pregnancy, this woman is actually at risk of developing diabetes after, of course, conditions like a polycystic ovarian syndrome, which is also common in people who tend to be obese, is also a risk factor. For clinical features, most of the time, especially when you are looking at type 2 diabetes, which we're saying more like insulin resistance in the initial phases, they tend to be asymptomatic. So they will have it, but they won't show symptoms. You can only catch them when you do screening. And that's why screening is very important. You do your screening and then you realize that, oh, wow, your fasting blood sugar is about around 11. No, this is serious. Most of the time, they don't know. Okay, so screening is very important. And that's why we say that even we as clinicians, at least every 6 months, we should try and, check our fasting blood sugar or something to know whether we are okay or not. Then once the symptoms start and you're going to be urinating a lot, that's polyuria, you feel like drinking a lot of water because, of course, obviously you're peeing most of the water out, and then you are constantly hungry. There's something we say about diabetes, which once you keep this in your head, you always understand what diabetes is. So a wise man once said, diabetes is starvation in the midst of many. Okay, so you have a rich man who has a lot of food, but this man has actually been banned from eating. When you go to the room, there's a lot of food there, but then the man is starving. So starvation in the midst of many, what does it mean? It means that if you take the patient's blood, there's a lot of glucose in the blood, but this patient is actually starving. Why? Because the glucose isn't getting into the tissues where it's supposed to go and affect, body change. So you realize that they will starve a lot. Initially, they will start as overweight because we are saying overweight is a risk factor. So initially they tend to be overweight, but as the disease condition progresses, because the body is starving, they tend to lose weight, okay? And then sugars would also have effects on blood vessels, it will have effects on nerves, so you end up having so many issues which we'll be looking at. So blood vision is one, you tend to have numbness, pins and needles, what we call paresthesias, and also because of the high sugar level in certain places, you are at risk of developing infections, commonly yeast infections. So most of the time, you tend to have candida and all sorts of infections. Okay. The high blood sugar is also able to sometimes paralyze your white blood cells, which would fight infection. So the risk of developing infections goes up. In terms of diagnosis, we're saying that once you have a fasting blood sugar, which is greater than 7.0, that is if you haven't eaten anything for at least 8 hours and we check your sugar should be less than 7.0. If your sugar is above that, then we tend to look at you and then we would want to get evidence of you being diabetic. If you've just eaten and then right after you eat 2 hours after that, we expect that your sugar should fall. Okay, but 2 hours after that, if you are doing sugars above 11.1, then we would say that you are diabetic. If we check your glycated hemoglobin, which tells us your sugar control over the past 3 months, and you are getting about 6.5% and above, then we would be worried and we would say you are diabetic. Of course, you don't do this lab once because pronouncing that someone is diabetic is a big thing. You're actually going to change the person's life in terms of medication, lifestyle, and all that. So you would want to repeat and be sure. And once you are getting these values, and sometimes there's a supportive thing coming from the symptoms or the clinical features, you can make your diagnosis. So know these 3 parameters: fasting blood sugar above 7, random blood sugar, that's 2 hours postprandial above 11, and then your glycated hemoglobin above 6.5. So if we say random blood sugar 2 hours postprandial, it's not like as soon as the patient eats, you go and take the patient's blood. No, then we'll say everyone is diabetic. You wait for 2 hours afterwards, and then you check, and then that's when you can use this value. And also for borderline cases or impaired glucose tolerance, for people who are at risk of becoming diabetes or developing full-blown diabetes, we would want to do what we call OGTT. So once we do our oral glucose tolerance test, there are parameters that we'll look out for. If you are exceeding the upper limit of these parameters, then in fact, you've gone beyond the borderline, and then we can make a diagnosis of diabetes. Okay, we are saying impaired glucose tolerance is actually a risk factor for developing diabetes in the future. So usually when you are doing a 2-hour postprandial glucose test and you are getting about 7 to 11, you put this patient in the impaired glucose tolerance, some further labs to be sure that the patient is not really diabetic. The good thing about impaired glucose tolerance is once you make that diagnosis, you can quickly change the patient's lifestyle. They stop doing all sorts of things, they exercise, they eat well, and most of the time it's able to control. We are saying that diabetes is progressive and irreversible, but once you have impaired glucose tolerance and you haven't developed full-blown diabetes, we can do something about it if we change the lifestyle and you are able to maintain this lifestyle. Then surely at least there's some protection until maybe later in life when you are old, and then you start seeing some traces. So the other investigations, we can also do a full blood count, especially if there's an infection and you want to take a look at your white cell count. You tend to get UTIs often, and even you have a patient coming to you urinating frequently, you want to look out for a urinary tract infection as well, just to be sure, because that becomes a differential diagnosis. And your urine RE would also show you if you have sugar or glucose in the urine. It would prompt you. A BU and creatinine, very, very essential, because we all know the effect that diabetes tends to have on the kidney. A lipid profile is essential, because we're saying that hyperlipidemia can also have an effect, and a liver function test is also good. So it's good to do your chemistries when you make this diagnosis, just like the way you do your chemistries when you make diagnosis of hypertension. Complications, you can have macrovascular complications, microvascular complications, metabolic complications. So vascular means that the diabetes is actually affecting the big blood vessels. And the reason for this is because the diabetes would predispose you to developing something like atherosclerosis. because it leads to destruction of the lining of the blood vessels. You can end up forming a plaque in there. Once you have this plaque, it leads to strokes, ischemic heart disease, because once you have that atherosclerosis due to the diabetes, blood flow will be reduced, getting to the vital organs. You can get an ischemic stroke and get an ischemic heart disease. There's poor perfusion to the limb, so you can develop a peripheral vascular disease. And then you can go ahead developing an ulcer, what we call a diabetic foot, okay? And the feet also changes, so then you have a classic diabetic foot. Microvascular complications, this is changes in the smaller blood vessels, so blood vessels of the eyes, blood vessels supplying the kidneys, blood vessels supplying the nerves. So you can have a diabetic eye disease, so can have a retinopathy, you can develop cataracts, you can develop paralysis of the extraocular muscles. You can also develop a kidney problem, so diabetic nephropathy is very essential, where the small blood vessels in the nephron or the glomerulus can become impaired, and so the function is sort of reduced and you end up developing a chronic kidney disease later in life. Or you can develop a diabetic nephropathy where you have the tingling sensations and all that. The risk of infection, and then of course the diabetic foot. I'm sure now during our clinic house, if you go to the surgical ward, you see a lot of diabetic foots there. Then metabolic complications like diabetic ketoacidosis and HHS, which we'll be talking about in a bit. These are all complications of diabetes. In terms of management, of course, once you make your diagnosis, it's not just about putting your patients on medication. There's a lifestyle change, which is very essential. So you need to advise your patients, you encourage them to exercise, they have to stop smoking. Ideally, they need to stop taking alcohol, but sometimes it's difficult. So you say minimal intake of alcohol. They cut down sugars. You rather advise them to eat the high fiber and then the unrefined carbohydrates. Then the fat has to also reduce. Okay, so basically lifestyle change. In terms of pharmacologic management, we have different groups of medications, and I'm sure now we all know about metformin, we know dionyl of the glibenclamide, we know about galvusmet, we know about meglitinide. So all of these are different groups of medications, and you need to know these medications because in the outpatient setting, this is what you'll be given, and you'll be combining and doing your cocktail, and you'll be doing your tailoring until you get the effective combination that would help control your patient's sugar. The target is that you want to get a sugar level of less than 7 in the initial phase. As it goes down, you're getting sugar level of less than 6. Fasting blood sugar level of less than 6. So you need to combine this, your medications, and we'll be talking about them. So initially, we'll first look at the oral hypoglycemics. So a common medication we tend to give is metformin. Metformin belongs to a group of medication called the biguanides. And you should know how it works, and it's not so difficult because we're saying that diabetes comes about through 2 means. 1, either the insulin is not being produced by the pancreas, okay, or 2, either you have some sort of insulin resistance. So the medication that you are given would either help the pancreas to make insulin or would either help your body to become more sensitive to insulin that is being produced, or worst case scenario, it will act as insulin. Okay, so biguanides here, example metformin, would work by increasing the insulin sensitivity, and also it would reduce the rate of gluconeogenesis. Gluconeogenesis means that they are making glucose from new sources, and once you are making glucose from new sources and your body is insensitive to insulin, this glucose will not be able to go into the tissues, and hence you develop hyperglycemia. So biguanides will prevent or will reduce gluconeogenesis, and it would increase the sensitivity of the insulin, so the insulin can work well. Okay, so because biguanide basically doesn't have a direct effect on insulin secretion, it doesn't cause you to make excess insulin. So the risk of hypoglycemia is reduced, okay? And also it doesn't cause weight gain. However, it comes with side effect, gastrointestinal side effect, nausea, vomiting, bloating, all those things. So that is one of the reasons why we would usually not give it to some patients. They are very good medications, but for some patients, you give it to them and they start having GIT complications. So you wouldn't want to give it to them. So you know how it works. It would, one, it goes to increase sensitivity of the tissue, and then two, it goes to reduce the rate of gluconeogenesis. It doesn't have a direct effect on insulin secretion. Unlike your sulfonylureas, for example, the glibenclamides and all that, and right now there are newer ones. They have gliclazide, you have glimepiride, and all these ones on the market. Of course, they come with trade names like your glimepiride is the Amaryl, your gliclazide, you are looking at your dimicron and all those things. So they come with trade names. It's good to know the trade names as well, or the brand names. So what a sulfonylurea does is the opposite of what the biguanides will do. The sulfonylureas will go and stimulate the beta cells to make insulin in the presence of glucose. So you see what it does. So because it's able to stimulate the beta cell, it can end up causing excess production of insulin, and this can actually lead to hypoglycemia. So if your patient ingests or takes overdose of a sulfonylurea, one of the risk factors is hypoglycemia. Okay, they can develop hypoglycemia. So we need to be very, very, very careful. And we are saying that sulfonylureas, their effects will usually wear off after 3 years. Why? Because as I told you, as the person has the diabetes for some time, the beta cells of the pancreas will eventually reduce in mass, okay? And so the production of insulin will be reduced. So you'll be giving sulfonylureas, but then the sugars will still be high. So ideally, in managing our diabetics, once they go beyond 3 years, we have to make sure we are reviewing their medication, because maybe they might just be on sulfonylureas and this won't be working because the beta cell mass that you expect the sulfonylurea to go and stimulate and make or to increase insulin production would have been depleted. So that is what we are looking at. There are examples there which I've given you. Tobutamide is suitable in adults because it has a short duration. And why is this important? We are talking about the risk of hypoglycemia. In your adults, you don't want them to be taking a very long duration one, because then that increases your risk of hypoglycemia. So the tobutamide here will help them in case of anything like hypoglycemia. The effects is sort of reduced because of its shorter duration. And these medications are all excreted by the kidneys, in the exception of gliclazide. So if you have a patient who has a CKD secondary to diabetic nephropathy, the kidneys are gone. You have to be careful the kind of medication you give. Okay, the patient has diabetes and the kidneys are gone. You can't go and give your glibenclamides and glimepirides and all that, because the kidney is responsible for getting rid of these medications. If you go ahead and you give it, then your patients will have issues because you'll be unable to get it out of your system. So you go for gliclazide. So these things are very, very important. If you are giving, sometimes, in fact, most of the time, most clinicians don't look at these things, and then they see a diabetic with chronic kidney disease, and then they just put them on any diabetic medication. You need to be careful. Okay, you go for your gliclazide because that is what is used in renal impairment. And then all those ones that we talked about, like your diuretics and all that, you need to stop them, because we said that they precipitate and they precipitate the glucose, and then they make your the diabetes worse. So you need to avoid those things. So This is the reason why we are doing internal medicine. It's not just internal medicine, but it's also what therapeutics. Okay. There's also a medication called DPP4 inhibitors. Yes, hi.
Yeah, Doc, please. I read somewhere concerning the glimepiride.
Yeah.
It's normally when you need an instant or immediate reduction in glucose, but I don't know if other ones like glimepiride and other sulfonylureas can be used when it comes to emergency reduction of the glucose, whereby somebody's had a crisis and
Okay.
the sugar at the instant.
Okay. All right. So I would say that it's partially not true. Why would I say that? Because if you want instant reduction of your glucose, you don't go for your glibenclamide. Okay. In practice, what we do is if the glucose level is too high and we want to reduce it, and at the same time, we want to be able to regulate it. We don't just want to reduce it. The reason why I'm sure they said that is because of what I just told you, that the sulfonylureas, because they stimulate the beta cells, they are able to cause hypoglycemia. So clearly, if they're able to cause hypoglycemia, then when you give it, the sugar levels will drop. But you can't control it in a patient who has hyperglycemia. So in such patients, I'm sure you've seen them being managed on the ward. We would rather want to give soluble insulin, which we can be given in graded doses, and we can keep measuring and we can keep measuring. Remember, something like glimepiride, the half-life is a little bit long. So if you give it, and after some few hours, 1 hour of your sugar monitoring, you come and the sugar is still high, you can't go ahead and give another glimepiride, because you end up overdosing the patient and you push the patient to hypoglycemia. So even though it has the potency to cause hypoglycemia, that is not the go-to medication when you want to reduce your sugar level. And yes, the other sulfonylureas also have the ability to reduce the sugar. Are you okay? Are you okay, please?
Dog, yes.
All right, great. So we'll talk about the DPP4 inhibitors, or the dipeptidopeptidase 4 inhibitors. And these are basically some group of new medications on the system. So you see common medications like galvosmith, which is a combination of a DPP4 inhibitor and a metformin. Okay. The DPP4 inhibitor and galvosmith, which is called Galvos, the generic name is vildagliptin. Okay. And what this DPP4 inhibitor does is that it prevents, or it inhibits the activity of DPP4, or dipeptidopeptidase 4. Okay. And this dipeptidopeptidase 4 is an enzyme. And what it does is it inhibits the activity of what we call GLP-1, or glucagon-like peptide 1. So let's go back. Glucagon-like peptide 1 is a very good what we call incretin. And what it does is that once you have you consume any form of glucose orally, glucagon-like peptide 1 is produced, and this glucagon-like peptide 1 improves insulin response. So it's good for glucose control. Okay. But this enzyme called DPP4 is able to inhibit glucagon-like peptide 1. And when it inhibits the activity of glucagon-like peptide 1, then clearly insulin response to will be what's reduced. So if we want to control our sugar, then why don't we come up with a medication that will rather inhibit the activity of this DPP4 and allow the glucagon-like peptide 1 to be able to work. And that's where vildagliptin comes in. It will inhibit the activity of the DPP4 And then once this DPP4 is inhibited, your glucagon-like peptide 1 can have a field day and then improve insulin response so that you can have a good glycemic control. So the side effects of that is nausea. Then you also have your thiazolidinediones. Okay, for example, you have the pioglitazone, you have the rosiglitazone. These medications work like the way metformin works. Okay, it reduces the hepatic glucose output, and it also enhances the peripheral glucose uptake by improving sensitivity. So just like the way metformin works. Okay, so sometimes we put our patients on this medication if the usual metformin and diurnals are not working. We come to this ones. Okay. So side effects: weight gain, fluid retention, heart failure, anemia, osteoporosis. So you need to be careful. If your patient has some form of congestive heart failure, already suffering from fluid retention, and with weight gain, you wouldn't want to give your thiazolidinedione. Okay. Then there's also a group of medications called meglitinide, which works like the way your sulfonylureas work. Okay, so just read on meglitinide as well. So to finish up with our therapy, let's look at insulin. And insulin is very essential because, as you know, some patients are on solely insulin. Okay, and for instance, if you are managing a patient who has type 1 diabetes and you are giving some of this oral hypoglycemics, it won't work because the oral hypoglycemic you are giving, like metformin, or maybe if you are giving your thiazolidinediones or whatnot, it's supposed to go and improve sensitivity of your tissues to insulin. But in this case, you don't even have insulin at all. So what do? You put a patient on insulin. Okay, and that's what we also do for patients who have type 2 diabetes. Solving the issue, we put them on insulin therapy. And also patients who have type 2 diabetes who have had it for some time and eventually the beta cell mass has reduced, we put them on insulin. So usually we have different types of insulin. So there's a short-acting insulin, and this short-acting insulin, in fact, there's something we call regular-acting and rapid-acting insulin, which has a shorter half-life and then works faster than all the group of insulins. Okay, then you have a short-acting insulin, which comes after the regular. It also has a half-life, which is a little bit longer than the rapid-acting, and then the duration of action is just a little bit longer than the rapid action. Then you have the intermediate acting, which has a shorter half-life than the first two, and then has a longer half-life than the first two, and of course the duration of action is longer than the first two. Then you have long acting. So it follows. So rapid, short acting, intermediate acting, and long acting. Okay, so what does this tell you? Clearly, if you are giving a patient long acting insulin, it means that you can just give once a day and it can last for about 12 to 24 hours. You don't need to give in multiple doses. You understand? So once the patient takes it, it will take the patient through the whole day. Then if you are giving your patient something like intermediate acting, then you are looking at giving a morning dose and an evening dose because the duration of action is like 12 hours. Okay. And then if you are giving a patient like a short acting, then you can decide that every time the patient is going to eat, the patient will have to take the insulin, during meals. So because of the shorter duration of action, about 6 to 8 hours. So if your patient is eating like 3 times a day, that's like 8-hour interval. So you would give when the patient is going to eat, okay? Or as soon as the patient eats, you give the insulin. So you can see that their names, they got their names basically because of their half-life and then their duration of action. And then it's good to know that the short-acting insulin, which is also known as the soluble human insulin, is what we use to manage hyperglycemia emergencies or hyperglycemic emergencies. So when they rush a patient and the sugar is very high and they say bring insulin, you don't go and take intermediate insulin or a long-acting insulin. You'll kill the patient. when you give, it will take a very long time before the sugar level will come down. And once that is the case, you find it difficult adding up the dose, okay? Because eventually when you do, the patient will go into hypo. Now, if you are giving a short-acting or soluble human insulin, you know that within within about 2 to 4 hours, you've hit the peak and all that. So the onset is very fast. Within 5 to 15 minutes is working and all that. So this is what you need to know about insulin. Just know you have the short acting, you have intermediate acting, and then you have the long acting. And then also you can have what we call the pre-mixed insulin, or what we call mixed-start, okay, which is a combination of the short acting and the intermediate acting, which we also give twice daily for managing diabetes for our patients, okay? So when they come in, it's an emergency and the sugars are high, you want to control with the short acting or the soluble human insulin. And once you get very good levels over some time, then you switch to the mixed-start, you discharge them on the mixed-start, okay? So basically, this is it for the basics of diabetes. If there are any questions, we'll quickly take it and then we would try and then go through the other aspect of diabetes. So Esther, your hand is up. So let me take Esther's question. Yeah. Yes.
Doctor, if you have to see a patient on 2 occasions and you do the OGTT and it's still at the borderline, you were saying that patient has the likelihood of developing DM. So
Yes.
if you're in the consulting room and you've seen her on 2 occasions with that pregnancy, and the first pregnancy she was borderline, second pregnancy she was borderline, what do you do? Is it that after postnatal you refer her to see the specialist, or what do you do?
Okay, so once you've seen them at the ANC and then of course borderline, it means that you have to try and institute your non-pharmacological management for this patient's lifestyle, diet, and all that for this patient. If it fails to work, the thing is that as the pregnancy goes on, initially it might be borderline, but as the pregnancy goes on, the placenta will get big. As the pregnancy progresses, the initial thing which was borderline will later become DM in pregnancy. Maybe today she's borderline, maybe at probably at 28 weeks she's borderline, but 34 weeks she realized that the sugar is high. You understand? So it's sometimes a bit difficult to get borderline. You might get borderline, but the next time she'll come with diabetes if she's not following up with the management. So for a patient like that, you need to keep a close eye, and if possible, you need to give metformin during the pregnancy, okay, just to keep the sugar under control. But if you do lifestyle changes throughout and the patient delivers, you still need to follow up on the patient. Most of the time, if it's gestational DM, the sugars will fall after baby comes out. Okay, so you do follow up and you counsel this patient after the 6 weeks period that in 3 months' time, try and check your sugar. So it's all about constant follow-up. So you have to check their sugar in 3 months' time. You want them to also check their sugar. You want them to also check their sugar in like 6 months' time, okay? And then, of course, the next 6 months, which will be a year. And then you counsel them, you let them know that because of the fact that they were at risk of developing gestational DM, they need to be conscious. It doesn't end there that, oh, patient has delivered. So the lifestyle, they need to be conscious throughout because there is a risk of developing, especially if there's a family history of diabetes. You have to let them know that because of the GDM and also probably the family history they have, or maybe they might be obese or there might be other risk factors, there's a risk of developing DM. So they need to be doing constant, at least every 3 to 6 months, checking their sugars, and if possible, HbA1c every 6 months. So it's all about follow-up, okay? So you don't even rush to refer them. You can just let them follow up at your end. But as soon as you realize that they would have issues or it's starting to go up, then you can refer to the specialist or the endocrinologist or the diabetologist.
Okay. All right. Thank you, Doc.
You're welcome.
Doc, I also have a question. My first question.
Yes.
The reason I asked was that I was reading on a CDC site, and and even Medscape, and they had really outlined the boundaries for insulin resistance, pre-diabetic, and diabetes. Because so I asked this question first, but then you said that they have criteria. You use them. There are a little bit of criteria in there that you use to measure. But then what I still don't get is in this our setting, our clinical setting, do they have a condition for this insulin resistance? Because when you look at this CDC, we had a criteria for treating insulin resistance, pre-diabetes, and diabetic itself.
Okay, so for what we do here, insulin resistance, once you say insulin resistance, it depends on the sugar levels that you are getting. Basically, that is what we do. We base our management on. Because if you go ahead and you say that, all right, okay, the patient has insulin resistance, the next thing we want to know is, so is the patient diabetic? Because it's not enough for you to say the patient has insulin resistance. Once you say the patient has insulin resistance, we'll ask you, why are you saying the patient has insulin resistance? And then you have to prove by saying, oh, because when the patient, because there's no way of finding the insulin resistance until you go ahead and then you do your investigations to check the level of the sugar. Unless they stated another way of finding the insulin resistance. But once you say a patient has insulin resistance, then it means that the sugar levels are basically, elevated. And that is the reason, or that is what is prompting you to say the patient has insulin resistance. And if the sugar levels are elevated, and then 2, you can take the blood and check the level, or do a quantitative, or check the quantity of the insulin. So in a patient who has suppression of the beta cells, or is not making any insulin at all, like your type 1 diabetic, or later in life your type 2 diabetic, you realize that basically the patient doesn't have any insulin at all. But in your patient who has your classic insulin resistance, if you try to quantify the insulin, you realize that yes, there's insulin there, all right, but why is it not controlling the sugar? And that is where you can come up and say, okay, even though there's insulin, the sugar is still high. So clearly, the next thing is that the patient has insulin resistance. You will manage it as you are managing a diabetic if you've gone beyond your reference ranges. If you look at this same Medscape and all that, they give you parameters: fasting blood sugar above 7.0, random blood sugar above 11.1. It is there if you take a look at your Medscape. And we usually would want to go according to that and our standard treatment guidelines and all that, rather than looking at CDC, because it's just not enough to say the patient has insulin resistance. If you're saying has insulin resistance, what are you trying to say? Are you trying to say that the patient has insulin resistance, but the patient is in the category of impaired glucose tolerance, or the patient has insulin resistance, but then it's recording a fasting blood sugar above 7 and a random blood sugar above 11.1, then clearly this patient is diabetic, and the diabetes is secondary to the insulin resistance. So you manage the patient as a diabetic. If the patient has impaired glucose tolerance, then it means the patient has some form of chance. It means the patient, in quotes, is borderline. So you would want to improve on the lifestyle. You don't need to put the patient on diabetic medications, because you're saying it's more of impaired glucose tolerance. You are hoping that your lifestyle modifications would help the patient. Are you okay with that?
So I'm a bit okay with it, because the reason why I'm finding it difficult to get it. But then your explanation makes me makes it clearer a bit, because now when a patient has insulin resistance, there's some kind of clear outlined symptoms that they've outlined and you experience. And when the person has a pre-diabetes or maybe diabetes itself, we have the same different kind of symptoms that they exhibit. That's the blurred vision. But then when it comes to the insulin resistant, they categorize it under the cardiometabolic part.
Symptoms.
Symptoms, yes. So, but it's okay. I will observe what you just said. Sir.
Yes, I mean, that will make it easier for you because you end up confusing yourself. Clearly, insulin resistance would follow metabolic pattern, right? But then this metabolic effect would eventually lead to you also having other effects. If you are saying insulin resistance and you are checking your sugars and your fasting blood sugar is above reference range, your random is above reference range, it's not just insulin resistance anymore, because this patient who has insulin resistance can end up developing blurred vision because there's insulin resistance, and in that case, sugars are not being controlled well. So there's hyperglycemia, and that can also lead to the complications where your full-blown diabetes will lead to. Do you get it?
Yes, sir.
So the real thing we do, and that's why when you come to the OPD, won't say, okay, let's check your blood sugar. We check blood sugar. Blood sugar is high. Okay, let's do a quantitative insulin measurement. Nobody will do that for you. So, because there's actually no point in doing that. Oh, okay, blood sugar is high. So let me go and check the insulin. And then if I check the level of the insulin, I will know if this high blood sugar or elevated blood sugar is due to insulin resistance or insulin deficiency. We won't do that. Okay, unless, of course, blood sugar is high, we are suspecting other things that could be due to the reason why the blood sugar is high. Then we want to investigate further and then look for other things. And that's where the secondary diabetes comes in, which I gave you the types that we tend to, which I gave you what we tend to look out for. Okay, but if not so, what we do is once you make a diagnosis based on the parameters that have been given, and this is not just STG or Medscape, these are parameters by the American societies, they are parameters by British societies. They are accepted parameters that once you are doing above 7, fasting blood sugar above 11.1, then this is it. Okay.
So, but then American Association of Diabetes, right? Also on their website, when you go there and you read thoroughly, it really outlines insulin-resistant pre-diabetes and diabetes as well, but with it reference points and how to treat all these kind of 3 things I've said. So I was just right now when you just said you said about the American Diabetes Association, because it's something I've been following for quite a long time now. And when you just said that, it clicked to me that they themselves on their website have a parameter for insulin resistance, have a parameter for pre-diabetes, and have a parameter for diabetes, and how all these 3 conditions should be treated.
Okay.
That's why I asked for the setting in the Ghanaian environment.
Yeah. So it's a general setting that we do. We manage it generally, and you need to understand them that way, because let me ask you one question. So if you say insulin resistance, okay, what is the end game of insulin resistance?
So the end game is definitely it will go into pre-diabetes then diabetes.
No, that is not it. It won't always climb like you have insulin resistance, so pre-diabetes and diabetes.
Oh, yes.
It won't always climb. You understand? It won't always climb like that. You get it?
Yes,
so
sir.
If you can have a patient who has diabetes, and this diabetes is secondary to insulin resistance, and that is what we term as type 2 diabetes.
Okay.
You need to understand it so that you make it easier for yourself. even if you search everywhere, maybe the Americans are trying to make things difficult for themselves. But if you go on the internet and what it will tell you, you follow, and then you see that insulin resistance, clearly your cells are not responding to the insulin, and this would lead to increased blood sugar level. You get it? But
Yes, sir.
of course, it's not a thing that happens and the next day you have increased blood sugar level. It's a gradual thing.
Yeah. Because some people can even stay with insulin resistance for the rest of their life.
Exactly. And that's why during the lecture, I said that if that is even the case, we are saying insulin resistant, obese people are insulin resistant, then all obese patients should be diabetics. But then it's not just like that. You start developing insulin resistance and then we say no, you are diabetic. No, the system also tries to work on it to control things. And that's why when you have other risk factors, then your chances of developing the full-blown diabetes goes up and you develop that at a faster time. Okay. But in Ghana, nobody would see you in the consulting room and say, okay, you have insulin resistance. I don't know if you get me. We'll test you. And when we test, what we are looking out for is the level of your sugars. And if we think you are borderline, then we are going to go into that range of impaired glucose tolerance, and we'll know what to do further. If we test and then you are above the parameters that we've given, because these are definitions that are clearly outlined. Okay. The American Diabetic Association, the site that you are looking at now, did they give specific values for insulin resistance?
Sir, I have to open, but I quite remember they were giving site specific values for insulin resistance.
If they give you value for insulin resistance, and this your value is below the 7.0 fasting blood sugar or the 11.1 random blood sugar, how would you even know your patient has insulin resistance in the first place in our Ghanaian setting?
Okay, sir, that's what I'm saying, sir, if it's different, because with them, they have that lab, they've introduced a new lab or a new mechanism for testing for insulin resistance.
Okay.
Where we don't have it yet. That's why I was asking, maybe if that testing mechanism has been introduced into the system here.
Yeah, so clearly, probably then that's it. Because what we are doing now, we won't test you. We would only see if you have impaired glucose tolerance, and then we'll say, okay, you have got risk factors for that. It's either you are in the middle, you have, or you don't have.
Okay. Yes, sir. Thank you, sir.
Good evening.
Yes, good evening.
Good evening. I wanted to say whether if he has further explanation, if he has any problem, I think he can call you personally and talk to you on it. So can we make progress?
Yes, that's all right. So we would move on. So any other questions, please?
Sir, I have a question.
Yes.
Sir, so as a physician, and you are very certain about the diagnosis you are going to make with your supportive laboratory investigation, everything. So how do you communicate such a chronic condition to a patient? Like, I want you to give us just a glimpse of how you would do it, because most often, if a patient is told that you are diabetic, the patient doesn't even take it forward. The patient will not even return again. So as a new physician, how am I going to do the communication? Must I involve the senior colleague, or how am I going to do it?
Okay. Well, you should be able to break, in quotes, bad news. You don't always have to involve a senior colleague. So it all starts from when you are requesting for the lab for your patient. Okay, that's where it starts from. You don't just say, you don't just say, oh, go and do this, go and do that. So I know how difficult it can be to break such news. For instance, you are suspecting a patient has a chronic kidney disease. Patient comes to see you. you take a history, you examine, you don't say anything to the patient, and you tell the patient, go and do a kidney function test and come. You've made the job difficult for yourself. Because what if it comes and then your urea and creatinine levels are elevated? Now, you are now going to find it difficult to break the news that, oh, the reason why I asked you to go and do this was because I was thinking this, and it's this. It makes it difficult. So setting up that rapport in the first place is essential. So you tell your patients that with these symptoms that you have, it's looking like, yes. So that is basically it. That is what solves most of the problems. And most clinicians don't do that and they get into trouble. But after that, you take the history and you examine the patient, that end communication before they go and do the lab is very key. So based on what you have, this is what we think it might be. And even per your examination, this and this and this is what I found. I want to be really sure, and this is the reason why I'm asking you to go and do this lab. You have sorted the issue there and there. And then you explain to the patient that if you do the lab and it's this, then it means this, and this and this and this are the options we have for you. If you do the lab and then it is this, then this is what it means. So your options are this. So even before the patient steps out of your consulting room, you calm the patient down because you've told the patient that if you do the lab and it comes and it's high, it's not the end of the world. You calm the patients down psychologically, the patient to be able to go and do the lab and come back to you. And once the patient comes back, you go through with the patient again. What I do is initially when we used to do paper thing, you put the paper in front of the patient and then you go through with the patient one after the other. You don't take the lab and look at it like a professor reading and then afterwards, oh, okay. And then you write medication. No, you don't do that. And now they have PC, so you can either turn the screen to your patient to see whatever is on the screen. And whenever you point and you explain, you tell them what this means. You have to involve the patient. Basically, that is it. So whilst you're involving them, they will be free to tell you every single thing or every single issue they have with whatever is happening there and then. And then afterwards, you have to try and tell them something to calm them down. That's all right. So especially for your diabetics, you know that lifestyle is very essential. You don't scare your patient by just saying, okay, I'll put you on medication. You have to let the patient know that this condition is sometimes due to this, and lifestyle plays a major role. So we would start with exercises, and it's not in all the cases. Sometimes the sugars are not so bad. You can start with lifestyle changes and you give them sessions to come. And then afterwards, after you do that, you refer them to a person who will do the exercise for them. You refer them to a dietitian and you refer them to a clinical psychologist. These are the three things. But if you think they need to start medication, then you tell them that the lifestyle is important, but then because of how high your sugar is, the lifestyle alone won't control the sugar. So I'm going to put you on this medication. What patients like to hear is, I'm putting you on this medication and the medication does this. Most patients don't like taking medications because they are scared of side effects. So you have to let them know. You have to let them have confidence in you that you are giving them the best medication they can have on the market. There are these medications that we can give. This medication does this. It will control your sugar, but it comes with this and this and this side effect. This medication does this. It comes with this. This medication does this. And patients, they usually like to, in our Ghanaian setting, they like to hear, oh, this one, it won't affect your liver, it won't affect your kidney, because that's what they are usually worried about. So you give them that option that they will know that this one doesn't have effect on the liver or the kidney. As soon as they hear that, trust me, they will take the medication. And after you've told them that, you tell them that, however, if you don't take the medication, your kidney will fail. You can get a stroke. That is the last bit. You put your complications in, you can get a stroke, your kidney will fail, this, that, and then you are done. So that's how to go about it. These are chronic conditions. You don't just say you are diabetic, so take the medication. You prime them before they go and do the lab. After they come from the lab, you take them through the lab one-on-one. As you are going through, they are also saying what you are saying. Then you give them their management options. Then you do a multidisciplinary approach with your dietitian, your exercise therapist, your clinical psychologist. If the sugars are poorly controlled on the next review, then you can go ahead and then involve the specialist. In some facilities, they would say once you make the diagnosis and you counsel them, you refer them to a specialist clinic so that they come and they see the specialist on their next review. That's how you go about it.
Sir.
Okay, thank you very much.
Sir.
You're welcome. Yes, hi.
Yes, I found the name of the test. It's called a homeostatic model assessment of insulin resistance, HOMO-RE.
Yeah. Okay, I'll take a look at it. But basically, we are not doing that here. Maybe with time, because this is a new literature, it has to go through, and it's not just in America. We have to accept it globally, and then we would include it in our guidelines with time. It takes time. That's why we do studies in the first place. So hopefully we can involve that. But as it stands now, we don't do that routinely here. Maybe if someone would do that, probably a person has been trained in America and then would want to start that. But for now, no. For now, we go with the reference ranges that I gave you, and then you manage accordingly. Okay.
Okay.
But you can send me a link on WhatsApp. I'll take a look at it.
No problem. I'll do that. Thank you.
Okay, so I think I can take a last question, and then time is fast spent. We'll quickly touch on one topic, and then our next session on Friday, we would do the other major topic. So are there any questions?
Oh, sir.
Yes, hi. Okay, so if there are no major questions, I think we can move on to the next topic. It will be brief, and then we can have a break. Okay.
Thank you, sir.
You're welcome. Please, can you see my screen?
Yes, Doc.
Okay.
Yes,
So we can touch on hypoglycemia, since that one is relatively shorter than hyperglycemia. Then we can have a full session for hyperglycemia, God willing, on our next section. Okay. So of course, we've talked about diabetes, and we are saying that per definition, we were talking about increased glucose level or chronic hyperglycemia, which is basically irreversible. One of the things that you should know when you are talking about diabetes is also the reverse of increased sugar level, which is a decreased sugar level to a point that you can end up losing the patient. And as clinicians, we are even more afraid of the reverse of hyperglycemia than hyperglycemia itself. Hypoglycemia will kill you faster than hyperglycemia, as we always say. And hypoglycemia is one of the common things that we tend to see during our management of hyperglycemia. Clearly, if you are managing your hyperglycemia or your diabetes, the main aim is to try and bring the sugar down. And sometimes during your management, you might end up reducing the sugar to a point that is even more dangerous than expected, and then you might end up losing your patient. So you need to know about hypoglycemia, some of the things that can cause hypoglycemia, and how to manage hypoglycemia. Okay. So in this case, we are saying that it's a condition that is characterized by a reduction. So you have an abrupt reduction in the plasma glucose concentration. So it drops to a point that you start showing certain neurological symptoms. Okay, so as we go ahead, we'll see the symptoms that it usually comes with. Once the sugar level drops below 4.0, we would say you are having some form of hypoglycemia. But then most of the time, these symptoms, this neurological symptoms or sympathetic symptoms that we're talking about wouldn't really start at that point where you've gone below 4.0. It would usually start once your sugar reaches about 2.8 and below, then you start having symptoms. And that is what would prompt us that you are developing hypoglycemia. And that's why it's dangerous. When you go below 4.0, you might not feel any symptoms at all. But when it starts going down, then you know that you are in trouble. Okay. So because of the decreased sugar level, and you know how important sugar is to function of body cells, especially the brain cells, which feeds or mainly thrives on glucose. Once glucose level falls, then the brain cells are going to suffer or they are going to starve. So you start seeing symptoms like or features like altered mental state, and also in a view or in a way to try and then get your body working. There's some sort of sympathetic overactivity, and then you tend to see some features like your pulse going up, sweating, and all that, which we'll be looking at shortly. So the pathophysiology here means that you expect that the liver would be able to push or release sugar into the bloodstream. Once the blood sugar falls, you expect that the hormones which act in the opposing way to insulin, so you expect that your glucagon and all those hormones would come in, and once they come in, they will be able to cause increased hepatic glucose output. Even in hypoglycemia, insulin also helps you. Insulin has a dual activity, so insulin helps in causing the body to push, or the liver to push some sugar into the bloodstream. Okay, so once you have a decreased hepatic glucose output, then your risk of developing hypoglycemia will go up. Okay, so how will this happen? Sometimes you give a patient excess insulin. Insulin in excess will rather have the opposing effect. Insulin in excess would inhibit production of glucose, that's one, whether from new sources or whether breakdown of glycogen. Insulin in excess or overdose of insulin would inhibit glycogenolysis and gluconeogenesis. And once this inhibition comes into play, then clearly you are going to have reduced blood sugar, and this will lead to hypoglycemia. Also, if you starve, you are not eating, you are a bit hungry and you are exercising, you have a condition like a liver disease, because the liver is supposed to store glycogen. And when we do chronic liver disease, you realize that we said one of the functions of the liver was to store glycogen. So once you have an advanced liver disease or liver failure, then the glycogen reserves will be depleted, and then you would have diminished amount of sugar or glucose to be released from breakdown of glycogen. So this would actually put you at risk of hypoglycemia. And also, if you take certain drugs or in certain substances like alcohol, it can impair production of glucose from new sources, and this can lead to hypoglycemia. So you can see that we're saying the brain consumes about 50% of the glucose that is produced by the liver. Okay, the brain basically feeds on glucose. So if you are not making glucose, then the brain is going to starve. Okay, so once there's decreased blood glucose level, there's brain dysfunction, there's sympathetic activation, you have the adrenergic system coming into play where the pulse will go up. You realize the patient's respiratory rate tends to go up, the patient starts sweating and all that. And then later, the neuroglycopenic or the brain dysfunction symptoms will follow, where the patient starts feeling a bit dizzy, there's altered mental state, and then the patient can collapse. So etiology, so if you have a diabetic, which we've just talked about, your DM patients who overdose insulin, and as we talked about, insulin would inhibit gluconeogenesis and glycogenolysis. So if they overdose insulin, or they take insulin shot and they miss their meals, okay, all of these things will lead to a diminished blood sugar level, or they go and exercise extensively after even taking their insulin. Then you basically use the glucose in the exercise, and then the insulin will sort of overwork and you end up developing hypoglycemia. Certain drugs, as I said, like ethanol, haloperidol, quinine, all of this, and even your sulfonylureas, which we talked about, can have hypoglycemic effect. If you have a non-diabetic and decides to inject himself with insulin, he would go into hypo. People try to kill other people, or people try to commit suicide by injecting insulin. If you have a tumor sitting in the pancreas, and this tumor is basically producing excess insulin, so there's something called an insulinoma. It produces too much insulin. It's like the opposite of what you get in diabetes. You end up making too much insulin, which will lead to hypoglycemia. Sometimes you can eat a heavy meal, and right after you eat, your body is forced to produce excess amount of insulin in response to the heavy meal you've taken. And this will lead to a brief episode of hypoglycemia. So sometimes you realize you eat heavy, and as soon as you eat heavy, all of a sudden you start feeling dizzy. It's because you've eaten too much. So your body has made excess insulin in response to the heavy meal that you've eaten. It's called reactive hypoglycemia. You can have conditions where you have diminished amount of glucagon, growth hormones, adrenaline. Remember, we said that an increased level of these hormones will lead to increased sugar levels in the blood. So clearly, when their levels are diminished, then you're going to have reduced sugar levels. If you have a condition where the liver fails, the kidney fails, or you starve, all of this can actually affect your glucose. Then the clinical presentation. So we said there's a neurogenic or the sympathetic aspects where the patient sweats, shaking, there's tachycardia, there's anxiety, patients will complain of hunger. And then there's the glycopenic effect where the patient starts having the weakness and then the dizziness. Then the mental alterations come in, they start behaving inappropriately, blurred vision, they have seizures, and then they can go into coma or they die. So when do we say a person has hypoglycemia? So we go according to what we call the Whipple's triad. Okay, we say that classic hypoglycemia, one, there should be documentation of low blood sugar, and we said 4, right? And we say usually the symptoms will start at 2.8. And 2, there should be the presence of symptoms. So if you have low blood sugar, maybe 3.8, but you don't have symptoms, it's not classic hypoglycemia. So the classic hypoglycemia, there's low blood sugar with symptoms. And as soon as we get sugar into your system, the symptoms should normalize. Once you have these 3 things, then we'll say that what you had was hypoglycemia or the classic hypoglycemia. And clearly your investigation, you need to check the blood glucose level. There are other things like full blood counts, which would help you, because if sometimes when you have some form of infections and whatnot, which can actually affect the way your body handles sugar, you need to know all these things. Your BE and creatinine, remember we talked about the kidney failing, LFT, the liver fails, blood CS, urine CS for infections. You can check the level of the insulin, okay? in case you are suspecting an insulinoma, then as I said, you can do a quantity analysis, or you can check the quantity of insulin. And in the case of insulinoma, the insulin levels will be so high. Okay, you can also check the level of cortisol, which would be what's reduced, because we said that usually a diminished these hormones like cortisol and growth hormones, once they go down, then your glucose level will reduce. C-peptide is a protein that is produced in addition to insulin. So if your body is making excess insulin levels, your C-peptide levels will also go up. And this is very important. If someone intentionally injects another person with high dose insulin and kills the person, when they do the toxicology, they will check the level of insulin. They will realize that the insulin levels were high. The next thing they'll do is they'll want to know if the person naturally produced that high insulin level, or if the insulin was exogenous or introduced into his system by someone else. So they go ahead to check the C-peptide level. If your C-peptide level is high and your insulin is high, then it means that, of course, you produce the insulin yourself. But if your insulin is high and your C-peptide is low, then it means someone introduced the insulin into your system. Okay, so C-peptide is very, very important. We use it to assess whether the patient has endogenous increased insulin level or was from exogenous sources. Then, of course, your CT scan and your MRI scan can evaluate and look for the source of a tumor which is producing excess insulin. Treatment is straightforward. Clearly, we all know about the 50-50, where when a patient, you're suspecting hypoglycemia, and then you quickly check and it's low, you rush and you give the patient 50 mils or 50% dextrose. That's what you give the patient. Okay. Sometimes if you have glucagon in store, you can give 1 milligram of glucagon to the patient. But then this glucagon shouldn't replace your 50 mils or 50% dextrose. That is the main thing, or the gold standard. Sometimes if you don't have 50 mils or 50% dextrose and your patient can drink, your patient isn't gone and can drink something, then you quickly have to give some sugary drink like Coke. Sometimes you have a cube of sugar they can put in their mouth. Okay. Medications like diazepam and octreotide inhibit insulin secretion. So they've also been used in the management of hypoglycemia, which is due to excess insulin secretion. But mainly the gold standard is 50 mils or 50% dextrose. So I think we are right on time. We'll quickly take questions and then we can adjourn and then meet on God willing Friday. So any questions, please?
Hello, sir.
Yes.
How about amylin? Measurement of amylin. You tell me the insulin level.
Can you spell that? I'm not getting what you're saying.
Okay.
Allergies.
Hello.
Say, I think his network is not good.
Okay. Okay, so when he comes back, but I don't know if that's, I didn't hear it well, but I don't know if that is what it's talking about. It's also just like a peptide that is just like the way the C-peptide is. Okay, and once you are producing your insulin, the body also, the pancreatic cells also produces amylin or amylin, as they say. And then usually we don't do it routinely. Okay, we don't do it routinely. What we do is that even in your hypoglycemia, you don't routinely measure your insulin level, except in a case where you clearly know that this patient is not diabetic, this patient is not taking any form of insulin, but the patient persistently is experiencing hypoglycemia. You want to know the source of the hypoglycemia. That is where you go ahead and you look out for your insulin level. And when your insulin level is high, then you can go ahead and do your scan. to find the insulinoma that we are talking about. But yes, it's a peptide hormone that is released with insulin, but then routinely we wouldn't want to be looking for that when we are talking about hypoglycemia. Okay. Any other question?
So no questions.
Okay, so we can talk about the complication of the metabolic complication of diabetes in our next lecture. That is the DKA and then the HSS in our next lecture, which will be communicated to you. I'm hoping on Friday we can have that done. Then we can move on to another topic. So have a pleasant evening.
All right,
Thanks
doctor.
for
Thank you
coming
very
on
much.
time today.
Thank you.
Sir,
Yes.
yes, sir, today your speaker is really good.
My speaker is good today.
Yes, yes, good today. It's good today.
I found the mistake, so I've dealt with it. Thank you.
Okay.
You are fixing the economy.
Yes, I have sorted it. I'm fixing my laptop first, then I'll fix myself.
Okay.
Then we'll fix the country.
Hey, Lorena.
All right.
Lorena.
Okay,
we are fixing everything.
Okay, so
You continue to fix. Don't worry.